Hi, my name is Idris Samala, and I'm happy today to present on the work I've been doing for the past few months now and why I came to CalTech for my summer research fellowship. So, robot assisted surgery. I'd like to talk about what it is, what problems are faced in this domain, and what problems we're trying to solve in the lab, and what solutions we think we've been able to devise to some of these problems. So, for the past few months now, I've been working with Professor Anima Anand Kumar here at CalTech in the computer science department, in conjunction with Dr. Andrew Hung out of the Keck School of Medicine at the University of Southern California. So today, here's our roadmap. I'll start off with a quick background of this domain. Then we go on to the problems that are faced in this field. Then I'd like to give a short history of surgery. So how we've done surgery in the past, how we do it today, and how we envision doing it in the future. So then we'll talk about laparoscopy and how robot-assisted surgery is a form of advanced laparoscopy, so robots in medicine. Then we graduate on to the data set that we used for this project. And then I'll talk about the artificially intelligent models we were able to train with these data sets. Then we'll look at the results we were able to devise from our project, and then a quick summary of my talk. And I'll finish with further experimentations that we think we can do to basically solve the pressing problems we face today in healthcare, and more precisely, surgery. So a quick background, robot-assisted surgery, what is it? So this is when we use robot actuators, so robot arms and tools during surgical procedures in the modern operating room. So the first truly robot-assisted surgery was done in 1991, but to really appreciate the genesis of this field, we need to go back to the 80s. This was when the United States military with NASA devised a research initiative whereby they're looking to solve the surgical problems they face with gravely injured soldiers on the battlefield. So they figured if they could have surgeons here at home operate in a tele-surgical fashion on soldiers on the battlefield, it'll make the situation a bit easier. So fast forward to 1989, this was a seminal year for this field. So this was when the first laparoscopic cholecystectomy was done. So laparoscopic cholecystectomy is fancy medical jargon for minimally invasive gallbladder removal surgery. And mind you, this procedure was done in a private medical practice. Now, you might be forgiven to think that a surgery this advanced would have been done at one of the medical juggernauts like Mayo Clinic, Harvard Medical School, or even Feinberg School of Medicine, but this was done at a private medical practice. So as you can see, we're truly democratizing healthcare with this technology. So for now, humans still control the robots via telesurgery, but there's no reason why we can't envision a future where surgery is done autonomously. Now, you can think of robot-assisted surgery as an advanced form of laparoscopy, and I'll talk about that in a minute. So what are the problems we're facing in this field? So as we all know, surgery is a high stakes endeavor. This is why medical students that go into surgery tend to have the longest post-graduation teaching, right? So surgical residency is about 5 years, and depending on the kind of surgery you're looking to go into, so neurosurgery, that's an extra 5 years on top of the 5 years of general surgical residency. Now, these are new tools that we're trying to bring into the medical domain. And as you can imagine, when new tools are involved, these can become different bottlenecks and they can have their own learning curve. So we're trying to mitigate these problems so we can seamlessly integrate robots into the surgical pipeline. Now, skill level, as you can imagine, is objectively related to surgical outcomes. So until recently, post hoc assessment and documentation of surgical procedures has been the norm in the hospital setting. So the problem with this is human-to-human skills assessment is very subjective, and in some instances, it's actually biased. So this is where we feel when we insert machine learning into the pipeline, we can really objectify the skills assessment process and really automate the recording and documentation process in the modern operating room. So currently skills assessment benchmarks are insufficient. So this is just a buttressing point of what I said earlier. So human to human skills assessment is highly subjective, and it's agnostic to the plethora of data that's actually available in the modern operating room. And we're trying to solve that with machine learning. So a quick history of surgery. So you'd be surprised that the way we do surgery today is not that much different from the way we did it 100 or even 150 years ago. Yes, the tools are different. Yes, the environment is much more advanced, but surgeons still have to do these long incisions on their patients to get to the organs they're trying to operate on. So on your right, you're looking at a laparoscopic minimally invasive surgery. Now, this is a step up from how we used to do surgery in the past, because the surgeons have these tools and an endoscope that could actually project the surgical area on a screen. But the problem with traditional laparoscopy is that the surgeon needs to relearn how to do surgery in essence, right? Because these tools, so a tool like this would have maybe a fenestrated forceps at the tip, and another tool would have maybe a cutting device or a cauterizing device. Now, if the surgeon wants to move the tip up, they have to move their hand down. If they want the tip to move down, they have to move their hand up. So as you can see, this is not a natural way of doing surgery. Now we move on to robotic laparoscopy, so robot-assisted surgery. In this instance, the surgeon is given 360 degrees of freedom. So they're able to move their hand in 360 because the robot arms themselves move in 3D, and the tip that actually goes into the patient also moves in 360 degrees. So the surgeon is given extra degrees of freedom. And also the surgeon has full sight of the surgical area because of the 3D projection of the module where the surgeon looks through. Now, we can think of this as a platform as opposed to a tool. So robot-assisted surgery gives us a platform where third-party vendors and startups could actually create new modalities that can connect to this system and basically add more functionality. And it has something called the EndoRisk technology. So it's an extension of the surgeon's hands plus extra degrees of freedom. Now, the premier surgical robot platform is called the Vinci surgical system, and it's created by Intuitive Robotics. So it gives us three components. So there's the visual system where the nurses could actually see the surgical area, and there's the surgical cart, which would consist of the surgical robot arm and the surgeon's console. So this sort of 3D VR type device where the surgeon can look through and carry out the surgical procedure. And under that, under the surgeon's console is something called the EndoRisk control. So think of it as joysticks that the surgeon can actually use to carry out a surgery like this that you're looking at on your bottom left corner. So a quick example of the benefits of minimally invasive surgery. So this is an example of a sternotomy. So it's a sort of a cardiac surgical procedure. So the surgeon has to do these long, grotesque incisions that run down the torso of the patient. As you can see right here, they use something, this ratchet-like device called a retractor, to keep the chest cavity open so they can access the organs. And the rule of thumb in surgery is the longer the incision, the better, because that gives the surgeon access to the internal organs. Now, the problem with this is the patient is left with these long, unseemly, and just grotesque incisions that just run down their torso. And when we look at other metrics, so besides the cosmetic disadvantage of invasive surgery, when it comes to other metrics like how soon the surgeon leaves the hospital, so how soon they're discharged, and if they face post-operative complications, a patient like this isn't doing well on all those benchmarks. So it's not unheard of for a patient to have post-operative complications a year, 2 years after surgery. Now, compared to a patient like this that went through a more minimally invasive surgical procedure, right? So not only are they better off cosmetically, when it comes to how soon they're discharged from the hospital, I see no reason why a patient like this isn't discharged in a day or 2 days or 3 days after a surgery. And when it also comes to post-operative complications, this patient is well off compared to this patient up top. So robot surgery skills assessment. This is the problem we're trying to tackle in the lab. So surgical robots simplify surgical data gathering, right? We all know that. And the data we're looking at is in the spatial, semantic, and temporal domain. So we focus more on the temporal domain, so action recognition. And as I said earlier, human-to-human skills assessment is subjective. This is why we're trying to use machine learning to objectify the process of skills assessment. Now, intraoperative, so during surgery and post-operative after surgery guidance is made possible with machine learning in the pipeline. And skills assessment is objectively related to patient outcome, right? So if we were to listen to the World Health Organization, they tell us that somewhere from 0.5 to 5% of all mortalities in the hospital is attributed to surgery, right? And another 25% of all patients that go through surgery tend to have post-surgical complications. So these are very pressing problems we're trying to solve with this technology. So a quick look at our data set. So we're using the sponge data set to train our models. So here's an example on the bottom right corner. So you see the robot arm with the needle. And what we're trying to do is we're trying to assess how well the robot is able to insert the needle at one of the target points. So this was labeled by 4 different medical students and cross-validated. So we're looking at 392 videos in MP4 format. And the task is actually split into different segments. So the first segment would be needle positioning. So the first position where the robot actually holds onto the needle. The next segment would be needle targeting. Then the next segment we're trying to assess the skills for is needle driving, as in entering the target point. And then we have needle driving, exiting the target point. And we finalize with needle repositioning. So we start the whole process all over again. So these are the benchmarks we're trying to assess the skill level for the surgeons on. So we do our pre-processing with something called the two-stream convolutional LSTM. So we're generating the optical flow imagery, and so this basically reduces jitter, and we compute the optical flow on every 5 frames. And so these are the results we get when we're doing our pre-processing. We get the RGB samples and the optical flow samples. So what I did in the summer is program an attention mechanism. So an attention mechanism tries to mimic the human attention mechanism during visual processing. So this is how we pay attention to domain-specific tasks, right? So here we have our RGB imagery and our optical flow imagery, and it goes, so at every time step, we concatenate the RGB and the optical flow images, which serves as input into our one-layer convolutional neural network for feature fusion, right? So the high-level knowledge of the ongoing task, the ongoing surgical task in the videos, and the low-level visual information in the images form basically the basis of our adjusting spatial attention mechanism. So both the low-level visual representation of the surgical task and the high-level knowledge of the surgery going on in the video is basically concatenated to form a vector input for our attention module, as you can see right here. So here's a visualization of the model architecture in full. So here we have the RGB and the optical flow images, and they serve as input into this AlexNet network here, right? This then outputs the feature representation of the RGB images and the feature representation of the optical flow imagery. So for the feature maps, we have the width and height, and the depth represents the channel dimension. So what we do is we then concatenate both on the channel dimension. So this is then fed into the convolutional layer, which reduces the dimensions into one feature map. The feature map is then concatenated with the hidden state of this convolutional LSTM. This is then fed through an attention multi-layer perceptron right here. So the attention multi-layer perceptron then outputs a 2D attention map. So the model at this point is basically trying to figure out what's the importance of each pixel at the input for this feature map. So this is then multiplied by this feature map right here to get a re-weighted feature map, right? So then the output is fed into a convolutional LSTM to update its hidden state. So the convolutional LSTM's hidden state is continually updated, as you can see by this circular arrow here. So then this is then, so the output is then fed through another multi-layered perceptron to predict the ideal or non-ideal labels of our data. And this, on this side as well, we feed this arrow through another multi-layer perceptron to predict the instrument kinematics, so as a sort of auxiliary supervision task. So we're going on to our results, and as you can see here, so the bottom graph represents the training benchmark we reached without an attention mechanism, and we were training at 78% top one validation accuracy. Now, the top graph here, this is where we use the video information, we use the kinematics data, and we use attention mechanism plus fine tuning by loading a model as a checkpoint. And we were able to get our top one validation accuracy to 95%. So as you can see, a very successful training regime here. So in summary, we went over what surgical robotics is. So it's a form of advanced laparoscopy, and we went over the problems that we're facing in this field. So the one we're most interested in is skills assessment, because it's subjective. So we're trying to objectify the skills assessment process. And it's a new tool. So with new tools come new learning schemes. So, and as we know, it's human-to-human skills assessment, human-to-human assessment in general in the operating room gives us insufficient benchmarks. We're trying to solve that with machine learning. And we went over our data set, which are short clips of sponge surgery. And then we went over our machine learning architecture, which consists of a FlowNet, AlexNet, attention mechanism, a convolutional LSTM, and a multi-layered perceptron. So with all our work, we were able to reach state-of-the-art results at 95% area under the curve. So further experimentation, right now, the video classification model is having trouble with certain fine-grained localized details, right? So if the robot arm holds the needle a third the way up, it has problems actually recognizing the needle. So we're looking also into multitask learning. So a single model with a feature extractor for all three tasks, and separate fully connected layers and heads for each task. We're also looking at end-to-end training. So right now we do some of our training. So our pipeline is not end-to-end. So some of our work is actually offline. So we're trying to change that and train end-to-end online. And we're looking to go from the sponge data set, the one I showed you earlier, which we consider the simulated domain 1. We're trying to graduate to the tube data set, which is much more analogous to human anatomy. So it's much more realistic than the sponge data set we've been using. So that would be in the simulated domain 2. And from there, we're looking to start using real surgical video to actually train our machine learning models. And we're also interested in self-supervision, which could also be an approach to move us from the simulated domain to the real surgical data domain. So to wrap up, I'd like to acknowledge a few institutions and a few people. So Professor Anima Anand Kumar here at CalTech has been immense and has helped me a lot, and her team at CalTech and NVIDIA has really been supportive throughout my summer research fellowship. I'd also like to thank California Institute of Technology for actually providing this opportunity, not just for me, but for all the students this summer. And also, I'd like to thank the WAVE Fellowship that's part of the student faculty program. They've been very helpful and very accommodating for us here this summer. Also, I'd like to thank our collaborators at the Keck School of Medicine at USC. And last but not least, I'd like to thank Facebook Inc. for providing the funds that has seen me through this summer of research. Thank you.